At this point, I would like to bring Frank back up, and he has put together cancer case studies using ozone and the IVC protocol. And immediately following that, I'll have Dr. Seeley come up and we will embark. I've got already about 10 questions up here, and so if you're thinking of questions, now's a good time to write them out and bring them up, and we'll address them in the Q&A session immediately following Frank's case presentation. So thank you. Frank?
Thanks. What did I do with the pointer?
Oh,
I got it. Okay. All right. So I just, want to kind of see what I got here. Okay, I got you. Okay. So I'm just going to kind of explain a little bit about what I'm doing, and then we'll see what happens with the Q&A session maybe a little bit. Okay, so some of the stuff you're going to probably could answer by now. How do oxidation therapies act to decrease, to reverse the decrease in oxygen utilization? Okay, so let's talk a little bit about the difference between an oxidation therapy and oxygenation therapy. They're similar, they have some overlap, but they're actually different in concept. An oxygenation therapy is where you provide more oxygen to the tissue. That's not what you do with oxidation. I've heard critics say, well, your ozone can't possibly work because the amount of oxygen you're giving in an ozone treatment is less than the amount of oxygen you get in half a breath. So that couldn't be working, and they're absolutely right. But they're thinking of it's like being a supplier of oxygen. It's not. Oxidation is a different deal. Oxygenation therapies would be like an EWOT therapy, an exercising with oxygen therapy, where you've got a mask on and you're inhaling oxygen at 100% and you're exercising, so you're getting a greater delivery to oxygen to tissues. Or hyperbaric oxygen, that'd be an oxygenation therapy. Just regular aerobic training can be an oxygenation therapy, assuming you don't get anaerobic in your training. At that point, it becomes an oxidation therapy. It basically just delivers more oxygen to the areas that are deprived of it. It does not directly reverse decrease oxygen utilization. Indirectly, it can. Because let's face it, if you have an area that isn't getting enough oxygen, it's going to have low oxygen utilization by definition. If one of your problems is endothelial in origin, and your endothelial cells are all swollen up, so your capillary diameter is effectively decreased, you can't deliver blood to the area, i.e. you can't get oxygen to the area, you can reverse that with oxygenation therapies. So they do tie in. So there would be a place to have somebody do an oxygenation therapy and tag it onto an oxidation therapy. There's a place for that. And you could give easily, and I would recommend this if you do HBO, I would recommend that prior to the HBO, you give your patient an ozone treatment, then put them in the chamber. That said, they are different. Oxidation therapies do not provide more oxygen. That's not what they're about. Instead, they do one thing, basically, at least in my mind, in terms of oxygen metabolism, anyhow. They do other things too, but they basically change the ratio, the NAD to NADH ratio. They're going to oxidize the NADH back to NAD. So kinds of oxidation therapies would be interval training. So interval training is where you're exercising and you're sort of warming up, and then you go at a pace that you could not possibly sustain. You go at a pace where after about 2 minutes, 3 minutes, you're in a state of complete anaerobic metabolism. You hurt, you're dizzy, you're a little nauseated, you're queasy, you don't feel so good, your heart's pounding, you're way short of breath, and you're thinking to yourself, I pretty much hate this. Now you're doing interval training. What you've just done is you've put your cells in a state of oxygen deprivation. They can't keep up what you're making them do. And as you do that repetitively, Short bursts. If you do a really long burst, you just kill yourselves. I'll tell you an interesting story in a second, but you do a short burst of it. So just a little bit of that. And as you do that over time, what's going to happen is your cells are going to upregulate the way they use oxygen. They're going to improve in the way they use oxygen because you're demanding that adaptation from them. However, you can't do it too much. So I'll tell you a story. I have a number of patients who are like they run marathons or triathlons, things like that. And of course, when you measure their oxygen utilization, it's off the charts good. That figures. Anybody with lousy oxygen utilization isn't going to be doing that for starters, and won't be able to do that. But these guys look great. But a few times they've come to see me, and I've checked their, and they usually typically see me once a year for this, and they come see me and I'll check their oxygen utilization. It's in the tank, totally in the tank. Guess what they did? They just ran a marathon about 3 days before. They destroyed their mitochondria. Flat out destroyed it, okay? And so what do I tell them? In each case, don't train, don't do anything. I want you sleeping and eating, and that's it. They come back in 2 weeks. I recheck them. They're right back to their former glory, okay? It's pretty sobering when you see that happen. And so that you can realize that one of the things you don't want to do is overtrain. How many people in here are guilty of possibly overtraining? There's one back there, okay. Mostly we're guilty of undertraining, but there are these kinds of people out there that will push themselves, and then you'll see these patients, they'll come in and I've had world-class athletes, or at least nationally ranked athletes, come in who are sick with chronic fatigue syndrome. How'd they get that way? They got that way because they didn't give enough rest period for the mitochondria to recover. So when you do interval training, you basically do it for maybe 2 minutes, and then you go into almost nothing mode for about 4 or 5 minutes. Let everything recover, settle down, all the free radicals are cleared out, all the acids cleared out, blah, 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 and then you feel pretty good, and bang, you go hit it again. And you don't do it too often. You maybe do 3, maximum 5 intervals at a session. But that would be a really good oxidation therapy for you guys, to get into some interval training. I would suggest 3 to 5 2-minute intervals 3 times a week. It'd be pretty nice. I see some good improvement with that. Intravenous hydrogen peroxide is a great way to go. I like ozone because ozone has so many, in a general medical practice, which is what I have, you can use it in virtually every patient you see for anything, from low back pain to dental infections to Lyme disease to cancer. I mean, it's got, the applications of it are huge. Hydrogen peroxide applications are much more narrow, but from a systemic perspective, hydrogen peroxide can be very, very helpful. EDTA chelation therapy, due to its effect on iron ferric to ferrous ratios, it has a certain oxidation aspect to it, so that you can tag all these things together. And I know a lot of docs will combine the chelation with either ozone, like I do, or with hydrogen peroxide. You can tag them together. Ultraviolet light blood irradiation typically is an oxidation therapy. Chemotherapy, radiation therapy, obviously, are oxidation therapies. Vitamin C in the high dose, in a sense, is an oxidation therapy, isn't it? So in the issue about can you mix vitamin C with oxidation therapies? You know, in the ozone world, this has been actually a no-no for many, 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 many years. Everybody thought if you mix the two, one's going to cancel the other. And I have to say I was a complete believer in that just because everybody told it to me. I never tested it out. Nobody, by the way, has ever tested it out. It's just one of those little myths that's handed down because it makes sort of sense, right? That, you know, an antioxidant therapy would antagonize an oxidant therapy. That makes sense. It's not the way it works, though. Over the last year or two, we have, due to anecdotal reports that I've gotten from other physicians and some of the reports we've been getting out of the academy at the annual meetings, I have now been combining high-dose vitamin C with ozone therapy. I've been combining, and I also like high-dose oral vitamin C with ozone therapy, and it works great. They work great tag team right on another. I'll give somebody 100 grams of vitamin C, and right after that give them an ozone. I'll give glutathione. That's another one. Glutathione's a potent antioxidant, and we see dramatic results administering ozone for about 30 minutes, then giving them a bolus of, say, 1,000 milligrams of glutathione, then another 30 minutes of ozone. We see with my Lyme disease patients, I have to tell you, it's almost a slam dunk. So you think they counteract each other, but they don't. So I'm telling people, listen, not only no longer don't have to tell your patients, don't take any vitamin C on the day of your therapy. In fact, you should tell your patients to do that. There is a synergism there, and I hope to maybe explain what's going on. I have a theory about what's going on there a little bit later. I'll get into that. Ozone forms peroxide. So, the thing is that when you inject ozone into a body cavity or into blood or whatever method that you're using, it instantaneously, in nanoseconds, reacts with lipids. It finds double bonds. It wants to give away its electrons and dismutate itself. So it instantaneously reacts with double bonds. So when we inject ozone, for example, into blood that's in a bag, the systemic way you usually do it is you pull blood out into a bag, and then you inject the gas, ozone's a gas, into the bag, and it interacts with the blood instantaneously. There's no more ozone in that bag. Okay, what's in that bag now is peroxides. So basically, it's a peroxide treatment when you stop and think about it. When you inject ozone into the rectum, 30 seconds later, there's no more ozone in the rectum. It's just oxygen. All you have in the rectum now is peroxides in the rectal mucosa. Now, these peroxides promulgate, they move, and so they do have systemic activities to them. When you put a patient in an ozone sauna, you make peroxides in the skin. If you give them ozonated water, you got peroxides going in the GI tract and so forth and so on. So the ozone reacts with the double bonds and the lipids, and all the double bonds, okay? So it really breaks them down into very short chain peroxides. These are little small molecules. These molecules can literally go through membranes. And so, and they last a long time. So the ozonides are short-chained. They can penetrate membranes easily. They're stable for a long time. So after you give an ozone treatment, you still got these peroxides around for at least a week. You can measure them if you want. Just do a serum lipid peroxide level, and you'll see they go up. They're selective reactive. I think what they do, and there's some good evidence to this, what they do is they get into the cells and they oxidize the NADH in people that have a low NAD to NADH ratio. Now, what do they do in people that already have a good NAD-NADH ratio? Nothing. They don't do anything. We've seen this. We've studied this, where we'll take somebody that's got already has good mitochondrial function, give them an ozone therapy, nothing happens. So if you're already in great shape, you're not going to benefit by giving yourself ozone, I don't believe. But if you're not in great shape, that's the way to do it. This just shows, there's your double bond. There's the ozone interacting, lysing the double bond, producing the peroxide. There's zillions of these peroxides. Nobody knows how to catalog them. They just call them ozonides. And they do all kinds of things. Most of them are in cell membranes, right? So they're in the red cell membranes and in the white cell membranes. And no matter where you inject, if you're injecting a bladder or whatever, it's going to hit membranes and start inducing intracellular changes. Basically, just to reiterate, there's your ozonide that we just made. It interacts to produce the NAD. Also, you get a little oxygen bust, but that's not really what's happening. Okay, so you could also say that oxidation therapy is going to be enhanced with certain things. They don't work in a vacuum, do they? So the NAD has to have something to work on. It's got to have some carnitine there. Okay. So there are certain things that can help with this. One thing that would be really obvious would be niacin. And so we find out that a lot of times, if you just give your patients, 500 to 1,000 milligrams of niacin a day, marvelous stuff starts to happen. And it can combine very nicely with ozone. The other intermediate I didn't mention is a riboflavin intermediate. That's FAD. So riboflavin seems to be valuable. Then anything has to do with methylation. Remember, they're one-on-one. So anything to do with methylation can be very helpful. You can actually even give oral NAD, and we do this. You give oral NAD. You can give it intravenously, I suppose. I just haven't done that. And so now you got NAD in the bloodstream because you just gave it orally or intravenously. Peroxides are going to, what they're going to do, that NADH that's in the bloodstream, immediately form NAD out of it. So does it really work in the real world? I presented a lot of theory to you guys, but unfortunately we don't have a lot of indisputable hardcore data. I will mention to you, by the way, though, if you go to the Academy website, it's AAOT.US, American Academy Ozone Therapy, AAOT.US. You can access a library there for free. You don't have to be a member. You can access a library there that'll get you, you can search over about anywhere from 4,000 to 5,000 different published studies over the last 50 years through that library. You can just plug in psoriasis, and you'll get any study of anybody who's published on ozone and psoriasis, for example. That said, how do we know this theory actually works? Well, this was an interesting paper that came out a few years ago, and it is called Pharmacological Stimulation of NADH Oxidation. That's what we're talking about. Ameliorates obesity and related phenotypes in mice. So the authors point out that the NAD-NADH ratio, quote, plays a crucial role in cellular energy metabolism, and the dysregulated ratio, in other words, decreased ratios, is implicated in metabolic syndrome. I'm flat out here to tell you that's what causes it. That's your cause of all the diabetes we got going on around here. So they use a substance called beta-lactone. They didn't use ozone, same idea though, and beta-lactone oxidizes NADH. And they did this in diet-induced obesity mice. And the conclusion was that the NADH oxidation strongly provoked mitochondrial fatty acid oxidation in vitro and in vivo, and dramatically ameliorated the key symptoms such as increased adiposity, glucose intolerance, dyslipidemia, fatty liver. I mean, is this like common? This is like what we see all day long half the time. This is good though. Then it says the treated mice also showed higher expressions of the genes related to mitochondrial energy metabolism. We shouldn't be too shocked, like SIR21, consistent with increased mitochondrial biogenesis. It actually makes you make more mitochondria. And the conclusions were that the pharmacological activation of NADH by oxidation by that beta-lactone resolves obesity and related phenotypes in mice, opening the possibility that may provide the basis for new therapy and so forth and so on. But if I were president, everybody that's overweight would go in and get an ozone treatment every day until they weren't overweight anymore. They'd probably get some dietary advice while we were at it. Okay. Another take-home message, it's uncommon that ozone therapy will successfully treat a patient as a standalone therapy. I do not believe it's a standalone therapy. You really have to integrate it. I've had patients that come to my workshops and they go home and then they call, not patients, but doctors, they call me back like 3 months later and says, I'm not getting results like you. I say, what are you doing? Well, I'm giving the ozone therapy. What else are you doing? Oh, nothing. You're not giving them thyroid? No. You're not giving them any B vitamins? No. You're not putting them on a low-carb diet? No. So it needs to be combined. So here's the point. Whatever your thing is, whether you're an acupuncturist or you're into detoxification or whatever your deal is, ozone will augment what you're doing. You don't stop doing what you're doing. You just add this in, you got another bullet in your chamber. That's all. Okay. Okay, so how's it helpful for cancer? In my world, I don't know how you guys are. Like, I only get the worst cases. Is that like, this is a wrong thing. This is wrong. I'll tell you a funny story. We had a little autistic kid, cutest little kid you ever saw. His name is Stevie. He's got the big horn rimmed glasses. He's about 7 years old, and just cuter than heck. And his mother says, I want to give him some ozone therapy. I said, well, it should work. There's a mitochondrial issue here, and there's certainly a detoxification issue. And we know that ozone, especially when you give it rectally, intensifies the P450 detoxification systems in the liver, in which autistic kids, they don't do that. So let's give them a little rectal ozone. Now I was thinking to myself, I don't know if an autistic kid's going to buy that. But anyhow, let's try it out. So I said, I also have a sauna. Let's see how he does in the sauna. So he goes in the sauna, and he comes out of the sauna. I said, Mom, how do you do? He said, oh, he likes it in there. It was kind of funny because we had to give him a bunch of cushions, and his head is just barely peeking out the top. And so then the next thing I know is we put him in the room, we're giving him a little rectal. And now here's Stevie standing there. Mom, 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 something's wrong here. This is not supposed to happen. And the kid's a genius. Yeah, sounds really wrong with that. Sorry. Anyhow, so ozone therapy for cancer. So anyhow, I don't know how I got off on that, but I get like the world's worst cancer cases. I mean, they're just god-awful horrible. Like not very many of them live through their cancer, like maybe 1 in 30 or something actually live through it. But up until the time they die, they have a really good quality of life. I mean, they probably only have it really bad for about 2 to 4 weeks. I mean, they're out riding their bike, and then 30 days later, they're dead. And that's what I can tell you my experience has been. We do IPTs with them. We do vitamin Cs. And we do a lot of detoxification. So the whole approach that the first speaker was a bit talking about. So what's the ozone? How's the ozone therapy helping? For one, we know, studies show that it increases antioxidant enzyme activity in healthy cells. The healthy cells, here's the thing, if you give an individual who has poor antioxidant activity, in other words, excessive oxidant stress, and you give them a bunch of vitamin C or antioxidants, are you fixing them? Not really, okay? You're Band-Aiding them. There's a guy with a headache and you're giving him aspirin. As long as you give him aspirin, the headache's not there. Take the aspirin away, he's in the same mess. Because what these substances do is they back up the enzymes. They back up the catalase and the glutathione peroxidase. The enzymes are what actually do the oxidant control. So if you don't have the enzymes, you got a problem. Yeah, you can make up for that problem by dumping in a lot of vitamin C. It's true, but as soon as you take the vitamin C away, you're back in the same bag, unless somehow at the same time you've upregulated their enzymes. And that's what ozone therapy, that's what oxidation therapies do. They upregulate the enzymes. In the course, I show slides after slide where you can see this definitely happening. Glutathione peroxidase goes up, catalase goes up, SOD goes up. All of them go up after oxidation therapies. And in patients, so I have a lot of patients that come in, and I measure these things on them, and they're low, and they've been on high megadoses of antioxidants for years, and they still have low enzymes. It doesn't fix anything. But you throw the ozone in combination with that, now you got something going. So it works great with the antioxidants and actually makes them work better. And in that way, it protects against so many of the side effects, because most of the if not all the side effects of radiation and chemo are due to its oxidant stress on healthy cells. It increases the chemoradiation efficacy. So the previous speaker alluded to that along with vitamin C by adding additional oxidant stress. My patients come in. My nurse, for a while there, worked at the local hospital over in the chemo center for about 2 months. That's about as long as she lasted. And she said, you can't believe it. I go over there, and they look like a bunch of zombies, and they're all dying. And people over here are like, reading their books and chit-chatting and so forth and so on. And, after they get their treatment, they go out. My office is right on a golf course, and they go right out and play golf. And it's just a world of difference. So these people, most of them you wouldn't even know had cancer, even though they have serious advanced disease. It induces anti-cancer enzymes. So the studies clearly show that TNF-alpha, interferon gamma, interleukin-2, all stimulated by ozone therapy. Direct contact kills cancer cells. So I've had cases where they have a non-penetrating bladder lesion, and we just shoot ozone in the bladder, and that's the end of that. Had a few cases of anal carcinoma, which were early discovered, that we just shoot ozone into the rectum, and that takes care of that. So if you can get it right on the cancer cells, you can get rid of the cancer. But mostly it's a systemic treatment. It can normalize marginal cancer cells. So if you we have this concept of marginal cancer cells. Again, these are the cells that we were previously talking about that are about ready to move over in that direction but haven't quite made the move. It can prevent them from going in that direction. And it stimulates apoptosis. So everything I just told you there, if you were to go to the course, I'd be showing you studies that back me up on that. How are we doing time-wise? About 5 minutes? Okay, let me see what I got here. All right, so okay, maybe we can squeeze a little bit more out. Different ways of doing it. The most common way is you pull blood out into a bottle or bag, inject ozone gas in there. The ozone interacts immediately with the white cells and the red cells in the bag, creating all these peroxides and inducing cytokines and everything. So you got this sort of activated blood, if you will. Then you run that back into the patient. You can also put it any place. We have an ophthalmologist in the academy that's injecting it into the eyeball. I haven't done that yet, but anyhow, you can put it any place. If you get the dose down, it's entirely safe. You can put it in any place. So in the intestines, in the vagina, bladder, stomach. I had a patient that was, what was that? Oh, gosh darn it, gastroparesis. So a severe case of gastroparesis in the hospital, came out of the hospital into my clinic with an NG tube in place. I said, what the heck? I took some syringes of ozone gas and injected right down the NG tube into the stomach, ozone gas into the stomach. I thought, I've never done this before. It's got to be fun. So I shot in maybe 500 cc's of gas into his stomach. He started burping. I started pulling gas out and stuff like that. Guess what happened to gastroparesis? Gone. Pretty amazing. So you can put in anything, any place you want, except lungs. Can't put it in lungs. So when you see that thing down there that says lung inhalation, that means that's a different sort of deal. The lung inhalation thing is you bubble the ozone gas up through olive oil. Terpenes are formed. It interacts with the olive oil to form vaporized terpenes, and then you inhale those terpenes. Now that's a whole nother deal. But that's the only place you can't put it. You can put it in ears. We for metastatic pancreatic carcinoma, we'll put it right into a peritoneal cavity. So I'll have an indwelling peritoneal tube, especially if they get continual peritoneal, if they get continuous ascites, then we'll pull the fluid out through there and shoot some ozone in there, and that can be very helpful. You can put it around tumors, put it right into tumors. I don't think it works very well right in tumors. You can use oil that's been ozonated. You can put the oil into body cavities. You can eat the oil. You can put it on teeth for periodontitis issues. You can ozonate saline and then drip in the ozonated saline. You can give it by sauna, so there's lots of ways you can do it. I did want to, before we go, kind of, you guys can tell me if I have this right or not, but I think this is sort of the deal, that the action of ascorbic acid is on the Fe3, and that produces the, yeah, okay, so I'm right there. So what happens is that the DHA then goes to stimulate collagen, and so this would be one of the ways that in a tumor that lacks catalase, one of the ways that you would generate the hydroxyl anion and kill the tumor. So as I understand it, that's the kind of way that can go. So this is what I think might be happening with the ozonides, is that the ozonides are actually producing more DHA and under the influence of lipoic acid. And what we typically do is we load the patient up with maybe 600 milligrams of oral lipoic acid about 60 minutes before an ozone treatment. And so we think maybe this is what's going on. I don't really know. But I will tell you they're synergistic. There's no two ways about that. Let's see what I got here. Okay, so just some real quick case studies. Rectal adenoma carcinoma in situ with high-grade dysplasia, 78-year-old female, 12-month history of rectal bleeding, difficulty passing stools, has a 3-centimeter rectal mass, CEA slightly up, 99 slightly up. Give her rectal ozone plus ultraviolet light 2 times a day, okay? And we do that 4 days a week for 2 weeks. The mass is half size, the bleeding is stopped. This is typical. Now, I might not cure this patient, but this is typical. Continued above for 3 more weeks, all the bleeding stopped. Stool is easy to pass. The mass has gone all the way down to 3 millimeters. At that point, we put some IPT in there, and that patient did really well 3 years later. Esophageal CA with Mets, this was an amazing case. 68-year-old guy with a 4-month history. He had just absolutely refused any conventional treatment. He couldn't swallow. He's having constant hiccups. He literally couldn't swallow his saliva. We just initiated the IPT, followed him by MAH. He did really, really well in about a month and a half. The swelling is almost normal. His hiccups was gone. He started to feel good. You know, 2-3 months later, the PET CT scan shows a 50% decrease in mass. We continued the treatments, and PET scan became absolutely normal. Couldn't find anything in him. About 2-3 months after treatment, he was eating and swallowing, and he looked like the healthiest guy on the planet. He lives in Alaska, and he went up to Alaska and started hauling in 400-pound halibuts in his boat. Here's a 68-year-old male diagnosed with squamous cell, pretty rough cancer. He had radiation at VA hospital. Oh yeah, this guy was good. So prior to each radiation session, we gave him hydrogen peroxide. So you gave him hydrogen peroxide, sent him right over for his radiation. So he had complete resolution of the cancer. This was like 10 years ago or something. No recurrence. And so his doctor goes to him and says, you know what, Fred, you have done so well with our treatments here that we want you to talk to the other patients and, you know, and tell them how great things are here at the VA. And he says, yeah, I will, doc, but I got to tell you, I lied to you. And he says, what do you mean? He says, you said you know, I shouldn't get any more therapies, and I promised you that I wouldn't, but I did in fact get hydrogen peroxide before all the radiation treatments you gave me. And the doc's response was, oh, great, well, tell all the patients that you got the hydrogen peroxide that really are. Not exactly. The doctor's response was, on second thought, maybe you better not talk to them. 65-year-old asymptomatic male with hep C. Oh, this is a great case. So this is a good case that exemplifies things. This guy just died about a month ago. When he first came in, though, he was in deep trouble. They gave him about like 2 months. This is like 2 years ago. Hep C, they started him on some sorafenib at the VA. They gave him a 4-month prognosis. His alpha-fetoprotein was 82. His enzymes were way high. We did the vitamin C every week. We gave him rectal ozone, because rectal ozone goes straight to the liver. Sure enough, a couple months later, his AFP is all the way up to 133. That's actually good. You know, getting some cancer die-off. His enzymes are coming down. The MRI shows an increasing mass. I take that to be swelling. And then the AFP starts going down. And at the last bullet there, say patient remains asymptomatic and fully functional. This is a year and a half later. His AFP is less than 30, and his liver function tests are normal. And that's all he's getting, folks, is that. And he did really, really, really well until finally he didn't. But this guy was in good shape, working, having a life, doing his thing, going fishing for a solid 2.5 years before he died. Oh, this is another good exemplary case. So here's a 51-year-old woman, diagnosed in 2007, had the whole deal, the mastectomy, the radiation, the whole thing. Basically, it was a failure of conventional therapy, bone mets, liver mets, weakness, anemia, just a mess, a disaster. Just a beautiful woman, just a real heartbreaker. We started treatment on her. Sure enough, man, you know what she complained about a year and a half later? Her hip was hurting her. I thought, oh, you got a bony metastasis. She said, no, I was riding my bike. I was on a mountain bike trail, and I crashed it and hurt my hip. I mean, that's a year and a half after I first started seeing her. Ultimately, the disease started to progress, and she declined. She went into liver failure and died in about 2 weeks. She went from riding her bike to dead in 2 weeks. She had a good 2 years or so out of that. Okay, that's just the vitamin C stuff. You guys know about that. Okay, colon cancer, 73-year-old male with a 3-year history of recurrent CA, also diabetes 2, infected foot, AFib, cirrhosis. These are my people. These are my guys. Weakness, diarrhea 4 times a day, all kinds of medications. Lab, unremarkable. Now that's remarkable that it's unremarkable. So we did some IPT, and we also followed it with MAH, and he did really well. Insulin potentiation, that's what I mean. So it's a form of chemo. You guys probably mostly know that. It's a form of chemo where you do lower dose and potentiate it with insulin. And I think this might, well, I got 2 more. Do I have a little bit time still? Okay, so a 78-year female with a 12-month history of rectal bleeding. Oh yeah, this is wild. She had a palpable rectal mass. And you know what happened was, after a while, she passed a piece of plastic. She had had some sort of bladder repair operation, and the doc left in some kind of piece of plastic in there, and it went out of the surgical site down into the rectum, formed an abscess. She got a cancer from that. And the next thing we know, we're in there, and I'm palpating her mass all the time, and out comes this piece of plastic. And when the piece of plastic came out, everything healed up really nicely. Pretty crazy. We were putting ozone into her rectum all the time. Okay, so a 65-year-old female, post 12 months of ineffective alternative treatments. I don't know what she was getting. Fungating, bleeding, fixed breast mass. It was nasty looking. She had a mastectomy on 6/10. All the margins were positive. And 9/10, she had pain and weakness. The CEA was 15. We started her on IPT. Each time she got the IPT, she followed it with an MAH. That's the ozone treatment. We did an ultrasound of her liver a couple months later. She was seeing a 50% response, and her CEA was down. She felt great, and that's the thing that, of course, I want to emphasize. On 4/11, the PT-CT showed dramatic improvement. The treatments continued but decreased. We just started spacing them out more. And finally, in July of 11, this is roughly a year later, the wound had healed up. She had no residual disease on PT. And then she went back home and didn't get any more therapy. And then subsequently, they found the brain mets, and they did some radiation to her, and then she died. So that's it. That just gives you a little taste of the little potpourri of some cases that really had fabulous results. But in general, every one of my patients does really well. They have a life. Even right now, I'm treating a lady that Jerry Taylor sent me that for the last, I want to say, year and a half, 2 years, has had a horrible situation with her cancer, but she's had a life. She doesn't have a problem. She gets up and she does. You'd never know there's anything wrong with her. She looks healthier than heck. So there it is. Okay, so thank you.
Before you go too far, Frank, excuse me, I just swallowed the wrong way. I have about 5 cards asking how you measure oxygen utilization and mitochondrial function.
The best thing to do is to email me, and I'll send you a lot of stuff I've written on it. So my email address is the word doctor, and the domain is pretty easy. It's antiagingmedicine.com. So doctor@antiagingmedicine.com. Just tell me you want some info on that. The gist of it is this. No, yeah, it's doctor spelled out, D-O-C-T-O-R. The gist of it is this. We use a pulmonary gas analyzer. So this is a piece of equipment. It's about yay big. And you wear a mask, and it's tracking your breath. So it knows how much oxygen is disappearing into your body simultaneous to how much carbon dioxide is coming out of your body. And again, remember, that's the definition of how efficiently you're processing the oxygen, is the amount of CO2 coming out relative to the amount of O2 going in. So we do that with the patient resting. That gives me their basal metabolism and all their basal data. And then I put them on a treadmill or an exerciser. And we do that for about 15, 20 minutes, and we keep ramping them up. Then we see how efficiently they do it under an exertional load. And based upon that, we take that information, run it through, I have a patented algorithmic program that runs that through, then gives you all the data on the mitochondria. And that's how we do it. It's simpler than heck. Anybody can do it. The equipment is, it's not that much. It's like 15 grand for everything, lights, buzzers, everything you want to do. There's actually codes for it. You can bill Medicare for it if you so desire. And it's a very handy test. It's easy to do. I'll be glad to tell you more about it. If you get any of my books, so I have a book called Bursting with Energy, and I have another one called The Type 2 Diabetes Breakthrough. They're very similar, but they both discuss this process to a certain extent.
While you're here at the mic, several questions regarding the legal status in various states and putting ozone therapy on your website. Is that a red flag, or have you had any problems legally along that line?
You know, that was more of an issue in years ago. We don't typically see that. We have doctors in all 50 states that are using ozone therapy. Now, you know, they don't really go out of their way to push it in everybody's face, so to speak, but they do use it. Most medical boards these days, you have to check with yours, but most medical boards these days will say, you know what, if you're giving your patient an informed consent about what you're doing, we're okay with it as long as you're not killing them. For those, now there are some people, and like I think Kentucky's a pretty rough spot. I think Ohio might be a rough spot. There are some states that you don't even want them knowing what you're doing in that regard. What can be helpful for people that are in environments that are unhealthy in that way is that the Academy has an institutional review board sponsored research project going on, has been going on for about a year now. We have maybe 30 co-investigators on this. I'm the principal investigator. It's an ongoing project studying the cost effectiveness, efficacy, and safety of ozone in its various forms of therapy. So I do happen to know that a certain amount of our co-investigators are signed up for that, that project. Pardon me? Yeah, well, it's what happens when you're doing research is that that research is no longer under the jurisdiction of your medical board. Okay, so the medical board says, you know, Dr. Shallengerger, I don't like the fact that you're giving ozone to these patients. And then your response is, yeah, well, this is part of a research project, so you don't have any jurisdiction on it. The FDA has jurisdiction on it, so they can come in and check out what you're doing. But as long as you're adhering to the protocols, this is all FDA approved, basically. It's what the IRB does. And so I know some doctors that are just doing that so that they don't have to piddle with their medical board. But it's really nice for us because we get a lot of really interesting information. And one of the things about ozone therapy that's pretty neat is it's cheap. You know, vitamin C can cost you. Ozone therapy is cheap. And so what we can show is real cost effectiveness, especially with certain things like pain. Ozone, I didn't mention this, but ozone will take away pain. So for your cancer patients that have like bone pain or something like that, shoot some ozone in there, they don't have it anymore. And so in terms of pain and other issues, ozone therapy is very cost effective, and we're hoping to be able to publish data. Ultimately, my plan is within 5 years it'll be covered by Medicare. That's my plan. We've seen this happen in some of the European countries, so I don't think it's completely unrealistic. Just need some data on that. But mostly you have to check with your medical board if you want to know what they're going to think about it.
Yeah. Question for Dr. Seeley. What is the average cost of a patient to go through the research that you're doing? Kind of, if you, yeah, you can use that, I think. Okay.
No. Oh, okay, now it's on, I think, yeah. So for the cost would be, our cost for IV vitamin C for a patient is 165 Canadian, which is roughly a little bit less. American would be about 150 now, I think. And then the consultations with the naturopathic doctors, those are about an hour and a half. The charge is 205. So patients are probably spending anywhere from, I would say, 350 on the low range, well, for initiation per month, up to maybe 1,500 per month, and even potentially higher if they're doing all the therapies. Most people are spending probably about $400 a month.
What's a typical 50-gram vitamin C infusion up in Canada?
About 150 to 185 per session.
Okay, thank you. And then another question to you, Dr. Seeley. They were asking using which type of glucometer do you use, or either one of you could answer that question in terms of using the glucometer as a way of monitoring vitamin C to see if you're getting it up at least into the what we would consider a pro-oxidant therapeutic range. I don't know if there's a one type that you prefer.
We use the Precision. I got the question earlier. I couldn't answer it, but it's the Precision Ultra, or not the Precision Ultra, it's Precision. And then there's a Precision Ultra, which does ketones as well, although I've heard they're discontinuing production of those. But that's what we use, and it works. It's been working effectively to get 350 to 400 range milligrams deciliter.
Do you do that same thing, Frank? You use...
Yeah, I don't know when we use either, but I do the exact same thing you do with same measurements and everything. 350, 400 over baseline.
Okay. Several questions about things that are added to IV vitamin C. Can you add ozone to Myers? Or do you start running into the problem of oxidizing certain nutrients or causing other side effects when you start putting a bunch of multiple nutrients in a bag?
You would not want to take, say, a bag with nutrients in it, like vitamin C or B vitamins or anything, really. You want to take that bag and shoot ozone into that bag. That makes no sense at all. You're just going to oxidize all the products in the bag. But you administer that bag to the patient. Now it's in their bloodstream, okay? Then you take an aliquot of that blood. Now, of course, some of those nutrients are in that blood, but how much? Very little. So you might be oxidizing them a little bit, so you piggyback these things. So yeah, we use Myers all the time. So a typical for me would be patient comes in, we give them the vitamin C. After the vitamin C, we give them an ozone. After an ozone, we give them a Myers. Send them over for a rectal and a sauna.
Does ozone therapy have any efficacy in lichen sclerosis?
Okay, so I don't really have enough information on that. I've had a couple of cases, and we've not done very well. I apply ozone oil to those cases, and I think it's been helpful, but it's not cleared it up.
Dr. Seeley, are there any major objections to IVC that this person was saying? Is there data or failure of treatment that we don't know about? I thought you covered that pretty well, but is any thoughts about why you wouldn't want to do IV vitamin C other than the normal contraindications?
Really, it would be based on cost and time for the patient. That's the major issue. And we're typically using IV vitamin C for more advanced cancer patients, not so much for early stage. We're using other things like oral natural health products, maybe subcutaneous mistletoe. So the majority of the patients that are doing IVC are advanced patients.
So we have a question here about what strength of ozone do you use? So that's the kind of thing you want to go to the course for. So if you go to the course, we do a course in October. It's already sold out. We do another one in April. That one's about 3/4 sold out. So don't wait until the last minute if you want to go to the course. You can access registration for that course either through the Academy website, aaot.us, or you can go to ozonecourse.com, and you can register for it. But you really ought to go to the course if you want to learn how to do this. That said, I wrote a book called The Principles and Applications of Ozone Therapy. There's a lot of protocols in that book. Just get it from Amazon.
Okay, Dr. Seeley, do you have any experience using high-dose IV vitamin C plus DMSO?
No, not at all.
Oh, okay.
Easy question.
We can talk, Virginia will be back on the stage this afternoon. That question might be relevant there. And what about using ozone in HIV patients?
Yeah, ozone has HIV. I don't want to make this too long an answer, but the problem with HIV patients, one of the problems with HIV patients is they have a shift from their Th1 immune-regulated mechanism to a Th2 immune-regulated mechanism. And this creates a ton of antibodies and immune complexes and makes them sick and gives them inflammation, and it's a big-time problem, gives them fevers and such. You can absolutely turn that around with ozone. So you're not going to cure them, but you will make them feel a lot better. And the disease will pretty much stop a lot of its progression, and it tandems in real nicely with the antiviral medications.
Yeah. Question about poly-NVA, giving it IV, and does it work similar to lipoic acid in upregulating the mitochondrial function of the cancer cells such that they they start using oxygen and start to have more apoptosis. Is that theoretically the mechanism of poly-MVA, or is it, what's your thoughts on poly-MVA? Anyone?
I've used poly MVA for quite a while. I have to say I'm not so sure it's all that great. I do the RGCC test, and it tests for poly. I don't know how they test it. I don't know how they determine if it's that efficacious. They usually give it say at best maybe a 30% rating of efficacy, whereas the chemo drugs are 78, 82% efficacy. So I have to say I'm not so sure it's that great, but sometimes I just use it just because it comes up on the test and it seems like a good idea.
Here's a question about how do you balance improved thyroid function if you don't use traditional blood tests? And for that person who's asking the test, and I don't know how you feel about this, Frank or Dr. Seeley, I think the new thing as far as as Dr. Broda Barnes used to say, he wouldn't give a nickel for a carload of the usual thyroid tests. And I think we might have something better now in terms of measuring the free T3, reverse T3 ratio, which I alluded to in my presentation. But generally, how do you assess thyroid function when you're dealing with your cancer patients?
Oh, that's a good one. Okay, in general, I'm of the opinion that measuring hormone levels, and I don't care what hormone level you're measuring, luteinizing hormone, testosterone, T3, I don't care what it is. In general, measuring hormone levels is an absolutely poor way to diagnose who needs a hormone. The ranges are gigantic. So unless you're at the top end of the range, you don't know if you're getting enough. The other thing is, remember, hormones by and large work with the cellular membrane receptors. So if you have a ton of cell membrane receptors and not much hormone, you get a good effect from the hormone. If you have a huge amount of hormone and very few receptors, you get a lousy effect from the hormone. And you can't measure the receptors, so there's an unknown in there. So basically, my advice to anybody would be, if you're going to diagnose a hormone deficiency in your patient, don't use a lab test to do it. Just diagnose it clinically. Now, with thyroid, I like to do basal metabolic rates. So that equipment I was just talking to you about a few minutes ago gives me a basal metabolic rate. And I like to do those maybe every 6 weeks on my cancer patients. And I'll keep pushing the thyroid, and I'm seeing what happens on the metabolic rate. Now, I do use hormone tests to follow my therapy. In other words, if they have a testosterone level of, say, 400, and I give them testosterone, I want to see where, is there a level now 2,000? So, I want to follow it that way. But I don't ever believe you ought to use a hormone level of any kind, saliva, blood, urine, whatever, to diagnose who should and shouldn't get a hormone. Specifically with thyroid, I never have a problem if I just use a basal metabolic rate. I want the basal metabolic rate to be at least 90% of predicted using what's called the Lusk formula, which is a formula that goes all the way back to the 30s, by the way. And if they're at 90%, I'm a happy guy, and I don't get any problems with them. A lot of my patients with cancer down in the low 70s, if not the 60s.
Yeah. And I would encourage all of you, if you don't have that equipment, a reverse T3 is becoming available in just about any lab. And just looking at that alone will tell you most of the people who have insulin resistance, fatigue, cancer, just about any kind of chronic illness will have an elevated reverse T3. And then when you throw in the T3 ratio in there, that gives you an even better way of looking at it. And any therapy that you do that improves their oxygen utilization, you'll often see the reverse T3 coming down, and you can watch the free T3. It may come up, but it's the ratio that really counts. And then they'll tell you that they're feeling better. The other thing I'd like to just comment about hormone therapy too is there's so many other variables that enter into the picture. A lot of people who are using the troches or lozenges, they're not using them properly. They're swallowing it. They're upregulating their thyroid binding globulin, their sex hormone binding globulin, so you have higher binding globulins, so you're not even getting the hormone, even though you have a better total. You may not have very good free. And so there's a lot of pitfalls in hormone management. And I really think you have to get to know your patients and some of the things. The main reason to measure hormones is to make sure you don't have someone that's taking too much in an effort to get an extraordinary result. I tell people that hormones are to help you feel normal, not extraordinary. And normal for a lot of people is extraordinary, but if you can do that safely, that's your best way of using natural hormone therapy. What about the use of artesunate? Are you using artesunate or resveratrol or any of the, or either one of you, if you have a comment on those? Those are new therapies that are being introduced for cancer patients.
Comment, we don't use either of those two as far as IV therapy. I know artesunate, there's a lot of, there's some good data coming out of Seattle that seems that the combination of artesunate with IV vitamin C is providing some benefit, particularly, again, for more advanced cancer cases. So we're looking at doing this, but we're not doing it yet. So.
Ditto.
Ditto. Okay, I think we're kind of got most of the questions covered here. Does anyone have any questions from the floor that you would like to direct? Yes. We got a mic coming to you.
You identified the common pattern was your patients with your approaches got extraordinary results, better quality of life, and then they died anyway, so to speak, with a kind of a rapid downhill course, but they died, I assume, most likely of their cancers. So question I had is, what is your understanding of what's happening there? Why that pattern? And it seems to me there's something that opens the door to, well, what's missing? Why is this pattern happening? And what might we add to get to change that pattern?
Boy, that's something I've thought about, huh? So there gets to be a point where you're beyond repair. That's all I can say. And certainly when you treat cancer, depending on what it's blocking, you could have a blocking process of the portal vein or some duct or some artery or something. You're going to have some problems based upon that. And even when the cancer goes away, the scar creates a problem. So my theory is that, number one, it's almost impossible to literally stop the process to the point that the patient's going to live forever and not die of the cancer. I have just not seen that happen in my practice. What we can do is slow it down. We can minimize the clinical effects of it. But in terms of taking an advanced cancer patient and, quote, curing them of the disease, it's happened. I've done it a few times. I think one or two of those patients I mentioned to you. But there's a whole lot of patients that didn't happen to. So I think realistically speaking, I'm just looking, and I want to have that conversation with the patients. I don't exclude the possibility that they could go into a full remission and even remain that way for many years. But I kind of related a little bit to what you were talking about in terms of the money. The money's a big issue as far as, I do pretty well until they run out of money. That's sort of, and I don't want to cop to that. Would you want to say something about that? Yeah.
Oh, okay.
I don't want to cop to that as an excuse, but it just does seem that way.
I want to say this is precisely the situation I was talking about earlier, and what Dr. Joseph Issels established in the 50s. He had advanced metastatic cancer patients, and he reported 97% of those patients had root canals or infected teeth. So this is precisely the circumstance, and we all talk about something's causing oxidative stress and we're relieving oxidative stress. I guarantee you'll help an enormous number of those patients maintain their remissions and, God forbid, have cures if the dental revision is a routine part of the cancer therapy. The toxins inside root canal treated teeth, I'll tell you right now, they're present in 100% of them. They were found by Dr. Boyd Haley. All of them are on the line of toxicity as much or greater than botulinum toxin, and they disseminate throughout the body, and they absolutely assassinate the antioxidant status of your body. So this was the you can't dry off until you're out. You can't dry off while you're still in the shower. So I strongly encourage you, and over time, we're going to try to get some dental therapy here at the Riordan Clinic and make it a larger part of the protocol, but try to find a dentist in your community. I'll do my best to help you through further educational processes with a dentist that might be open to this. We'll be having additional seminars down the road, but you will get substantially extended improvement, not only in your cancer patients, but in all your chronic degenerative disease patients.
Thank you, Tom. I think another message here is that we are good at initiating what we know, and when we have an initial response and the patient does well, we keep using that thinking this is it. And I think as clinicians with cancer patients, if we can be relentless in the search, and granted financial limitations do begin to apply, patients just kind of get tired. I mean, no one wants to be a cancer patient. Actually, the people who go on living their lives as if they weren't cancer patients, in my observation, actually do better. But under the surface, they should be asking that question, what else could be going on? And I know when I see people back and they're doing better, it's kind of like pat them on the shoulder, hey, great, glad to hear you're doing well, keep up the good work. And really, I should be thinking what else might be lurking below the surface that I could get this patient interested in so they don't get into that state of subtherapeutic complacency that then sets the stage for the recurrence to occur. But it's in the world of busy clinical medicine, it just doesn't always happen. Yes.
How effective is the ozone sauna compared to, how effective systemically is the ozone sauna compared to a major therapy?
We had a fellow by the name of, gosh darn it, Victor Marcial Vega.
Oh, Victor Vega,
You know him?
Yeah.
Okay, so he's been using ozone a lot in his work, and he presented the Academy 2 years ago, and really had some remarkable data on a lot of advanced cancer patients, and he's doing like what most of us are doing. He's incorporating everything in there from vitamin C to chemo to whatever, and he's big on the saunas. Really big on the saunas. He even made his own special sauna, which is different than the sauna all the rest of us use. All the rest of us basically, it's like a steam chamber. You're sitting in the steam chamber, and then you pulse ozone gas into that chamber periodically, like for 5 minutes, every 10 minutes or something like that, so that your ozone gas is touching on a vasodilated, moist skin and creating peroxides in the skin. Where are all the dendritic cells in your body? Mostly in the skin, right? So it is a dendritic cell treatment. I look at it that way, and I think to myself, it's probably got properties to it that the blood treatment doesn't have. Obviously, it's easy to tolerate. There's no IVs. You can give it to little Stevie, the autistic kid. It's a no-brainer in that way. And it might be very beneficial. Marcial Vega, what he did is he created one where he's got this gigantic system that ozonates the water, and then they sit in there and they get continually sprayed with heavily ozonated water. It's a different kind of system. And he does that quite frequently, like every day. And I don't have any hard data, and neither does he. And there actually is some hard data on the use of saunas with athletes. And so you can see their VO2s improve. So we know something systemically is going on that way. But I have to say, clinically speaking, I think that it's a very valuable thing that people might want to do. We have one in the clinic. It's easy enough to do. No, this is an ozone steam sauna. It's not an infrared sauna. So they sit in a steam box with their little head sticking out the top. It steams up in there, and there's a unit that pulses ozone gas into there while they're steamed up in there.
I'm sorry, we're going to have to take our lunch break now. I'd sure like to thank Dr. Seeley and Dr. Shallengerger. I think it was a fabulous morning. And I want to just kind of give you, keep in mind that you need to check out between 12 and 1. They will keep your things at the front desk. We will at 1 o'clock. Now we're coming back today a little earlier than what we did before. 1 o'clock. We're going to have Michael Gonzalez and Jorge Miranda talking to us about the variables that impact the clinical effectiveness of IVC in cancer care. And then we'll have a couple panels this afternoon after that. So we'll see you at 1 o'clock.